Hi guys, it's Olivia here. Welcome back to your Endocrinology chapter. Today we're going to be talking about diabetes insipidus, which is going to be another one of these diseases involving that hormone, antidiuretic hormone or vasopressin. So great to be aware of this one because it does involve a hormonal pathway, so that means there's a lot of ways they could test you on this on step one. Now there's two types of diabetes insipidus that I want you guys to be aware of. The first type is the central type. So when you have central diabetes insipidus, our problem is going to be a production problem. Remember, our antidiuretic hormone is going to be acting in the distal convoluted tubule as well as in the collecting duct to increase water reabsorption from our urine, so make that really concentrated urine. When we have no antidiuretic hormone, that then means that we are going to have less water reabsorption. So we have less water being reabsorbed from our urine. That's going to lead to increased water loss through the urine and some really dilute urine. So what causes our central diabetes insipidus? Well, antidiuretic hormone is made by the hypothalamus, as we mentioned, but it's stored in the posterior pituitary. So posterior pituitary pathologies can also lead to a problem with ADH production. You can have malignancies, different types of cancers that can involve the posterior pituitary and lead to a problem with ADH production. Also, traumatic brain injuries, so damage to your brain, the production center for ADH, can lead to diminished ADH production. Subarachnoid hemorrhage, again, just damage to the structures that are producing ADH. Meningitis, surgical trauma, and ischemia. Again, if you're not getting blood supply to the structures that are going to be secreting that ADH, they can't do their job. And a great example of ischemia is Sheehan syndrome. So Sheehan syndrome is specifically postpartum for women who lose a lot of blood during labor or during their C-section. Because they have lost so much blood, they're going to get ischemia to certain parts of their body. In this case, those structures that are involved with the creation and the secretion of antidiuretic hormone, that will lead to less antidiuretic hormone in circulation and give us our diabetes insipidus. Additionally, there's a couple kind of zebras that can cause diabetes insipidus. So Langerhans cell histiocytosis is one of them. And Langerhans cell histiocytosis is going to be this pathology that involves the proliferation of Langerhans cells, dendritic cells, that can't do antigen presentation or T cell stimulation. So it's this autoimmune kind of disease. It can lead to diabetes insipidus as well as osteolytic bone lesions, ear infections, things like that. Additionally, several other autoimmune diseases can also present with diabetes insipidus. So these are kind of more of the left field ones that could come up on step one, but great to be aware of just the same. Now, the other cause of diabetes insipidus, instead of a central cause, is a peripheral cause or a nephrogenic cause. These two are kind of used interchangeably. So you might hear peripheral diabetes insipidus, or you might hear nephrogenic diabetes insipidus. And this means that we have ADH that's being produced. ADH is in circulation. However, it's not acting at the collecting duct. It's not exerting its effects. And ADH usually is going to bind to these V2 receptors in the collecting duct. V2 receptors are the ones that are going to be responsible for inserting more aquaporins into that membrane. V1 receptors are more in the vasculature and responsible for the vasculature effects of ADH, but V2 are going to be the ones in your distal convoluted tubule and your collecting duct over here. So those are the ones that are going to be defective in our nephrogenic diabetes insipidus. When they are defective and we're not seeing the effects of ADH, this is pretty much the same pathology that we saw with central diabetes insipidus, which is why it's called the same disease. So we see less water reabsorption because ADH isn't there to pull that water out of the urine. This is going to lead to more water in the urine, so more water loss and dilute urine. The causes of nephrogenic diabetes insipidus are different as well. So these causes are usually going to involve drugs. So first there's lithium. You can also have amphotericin B, which is a very strong antifungal that has a lot of side effects, including diabetes insipidus. And then finally, demeclocycline. And demeclocycline, if you'll remember, is actually used to treat SIADH. And because it has this function of decreasing the sensitivity of these V2 receptors to antidiuretic hormone, it's very useful to treat SIADH, but can also cause diabetes insipidus. Finally, certain electrolyte abnormalities can also lead to diabetes insipidus. Specifically, hypokalemia or hypercalcemia can lead to a lower responsiveness to antidiuretic hormone and sodium reabsorption. So how is that going to present? Well, you are going to present with polyuria, first of all. Remember, we talked about how this water is going to be still in your urine because it wasn't reabsorbed from our distal convoluted tubule or from our collecting duct. So you have the polyuria. You also are going to have polydipsia. You're really thirsty because you're trying to replace that water that you just keep peeing out. You're peeing out at night, so you have nocturia, and all of this peeing out of the water and your inability to catch up with your thirst is going to lead to dehydration and the symptoms of that. So poor skin turgor, maybe some dry mucous membranes, things like that you think of with dehydration. Additionally, because you're losing all this water, you're going to have increased concentration of some of your electrolytes, including sodium, other electrolytes, and this can lead to muscle weakness, extreme thirst, like we already talked about, confusion, lethargy, irritability, seizures, loss of consciousness. So all of those things that can come with different electrolyte disturbances. If you think that you have a diabetes insipidus and you're trying to diagnose it, we're going to use our osmolality. Again, remember that high osmolality equals more concentrated. So I always like to think of osmolality corresponding to concentration. So increased osmolality, increased concentration. Low osmolality is going to equal less concentration, so more dilute. In diabetes insipidus, we are going to have low urine osmolality, and that should make sense to you because we have very dilute urine. We are unable to extract that water from our urine, so we are leaving a lot of water behind in our urine. If we add more water to the Gatorade, that makes it more dilute. So we have a more dilute urine, which means we have a lower serum osmolality. It is less concentrated. Similarly, we're going to have increased serum osmolality because we're getting rid of all of this water. So we're peeing out all the water, meaning there's less water left behind in our blood. So we're going to have higher concentrated blood, so a higher serum osmolality. You may also have hypernatremia or increased electrolytes like we talked about above. So if you see this picture, you're already suspecting that you have a diabetes insipidus. But how are we going to distinguish between central and peripheral or nephrogenic? Well, we're going to do this through something called the Vasopressin challenge. And the Vasopressin challenge is basically you give a patient that you have suspected diabetes insipidus vasopressin and you see what happens. If our patient has central diabetes insipidus, remember we don't have any antidiuretic hormone in circulation, and then we give them vasopressin, what do you think is going to happen? Well, the problem was that they didn't have any antidiuretic hormone. However, they can still respond to antidiuretic hormone. So when you give them vasopressin and you replace that antidiuretic hormone, you're going to see a normal response to antidiuretic hormone, and that is pulling water out of that distal convoluted tubule and that collecting duct. That's going to lead to decreased urine volume, right? Because we're pulling water out of the urine, and increased urine osmolality. So that would be the response to the vasopressin challenge if we had central diabetes insipidus. If we had peripheral or nephrogenic diabetes insipidus, on the other hand, and we did a vasopressin challenge, it doesn't matter if we have antidiuretic hormone present or not, because the issue here is that the receptor is not responding appropriately to antidiuretic hormone. So increasing the concentration of antidiuretic hormone isn't really going to do much. Our kidneys still aren't going to respond. And thus, when we do the vasopressin challenge with our peripheral or nephrogenic diabetes insipidus, we're going to see no change in urine volume, no change in urine volume, and no change in urine concentration or osmolality, which is directly contrasting to our central diabetes insipidus, where we would see a significant response, decreased urine volume, and increased urine osmolality. So this vasopressin challenge is going to be a great way to distinguish between central and peripheral diabetes insipidus, and a great thing for you to remember for your boards. Now, in conjunction, I also want to mention primary polydipsia, which can kind of masquerade as a diabetes insipidus in a test question. So primary polydipsia just means that you are super, super thirsty and you are drinking a lot of water, but it's kind of more of a psychological drive to drink water, if you will, rather than actually a physical thirst. So you're just drinking a ton of water, and because you're drinking a ton of water, that is why you're going to have increased urinary volumes. So if you have primary polydipsia and you do the vasopressin challenge, what's going to happen is you're actually going to get hyponatremia. Why are you going to get hyponatremic? Well, if you have primary polydipsia and you're drinking a ton of water, vasopressin should be super, super low because you are drinking so much water that it is threatening to dilute your blood. So appropriately, your body wants to pee out that extra water because it's saying, hey, I don't need this. So ADH levels will be really, really low in primary polydipsia. If you give them vasopressin, however, you're then telling their body, hey, why don't you hang on to all of this extra water? Why don't you keep that in circulation? And hanging on to that extra water, it's what is going to dilute your blood and give you hyponatremia if you do the vasopressin challenge in primary polydipsia. Additionally, with primary polydipsia, we usually diagnose it through something called a water deprivation test. And this basically means that we tell the patient, no, you can't have any water. We are cutting you off. You are are limited on water, and when we deprive them of water, their urine osmolality should increase. This is because once they're not taking in as much water, then their ADH finally gets activated and their body says, okay, phew, we're not drinking so much water that we're threatening to dilute our blood, so now we actually do need some of that water, we need to hang on to it, and the ADH is going to turn on. So that water deprivation test is going to be a great way for you guys to distinguish primary polydipsia from central or peripheral / nephrogenic diabetes insipidus, and a great diagnostic feature to be aware of here. Now finally, how do we treat our diabetes insipidus? Well, if we have central diabetes insipidus and the problem is we're not making ADH or vasopressin, the treatment is give them vasopressin. Give them vasopressin or desmopressin. You might see it written as DDAVP. Give them vasopressin or desmopressin, replace the thing that they're not making, and they should be good. It's a little bit more complicated with peripheral or nephrogenic diabetes insipidus. We are going to treat peripheral / nephrogenic diabetes insipidus with either hydrochlorothiazide, which is going to increase their proximal water and sodium reabsorption, so kind of a workaround for not having ADH functioning appropriately. Amiloride is going to be most helpful to treat diabetes insipidus secondary to lithium toxicity. And then finally, indomethacin. And indomethacin is going to inhibit prostaglandin synthesis, and prostaglandins are ADH antagonists, so once we remove those prostaglandins, hopefully ADH will function a little bit better. Now, I know that was a lot of information. Let's quickly review what we talked about in this video. So first, let's talk about our central diabetes insipidus. This is going to be caused by anything that messes with your brain, so malignancy, traumatic brain injury, ischemia to the brain, autoimmune diseases, trauma, things like that. The pathology is that we're just not making antidiuretic hormone. So we don't have antidiuretic hormone. It can't do its job, and that's why we're getting dilute urine. So antidiuretic hormone, because we're not making it, is going to be really low. When we do the vasopressin challenge, we are actually going to see a response though, because the problem is we just don't have ADH around. It's not that we're insensitive to it. So ADH, when we administer it, can do its normal job, and we'll have more water reabsorbed from the urine, leading to decreased urine volume and increased urine osmolality with the vasopressin challenge. And the treatment is just to replace what we're not making, give them vasopressin or give them desmopressin. Peripheral or nephrogenic diabetes insipidus, on the other hand, is going to be caused by drugs, primarily lithium, amphotericin B, or demeclocycline. It is going to be an ADH insensitivity, so ADH might be present, the levels might be high or normal, but it's just not doing its job. And that's why when we give them more ADH, we're not going to see any change with the vasopressin challenge. Nothing is going to really happen, because the problem isn't that we don't have ADH, the problem is that we're just insensitive to it. The treatment is going to be hydrochlorothiazide, amiloride, especially if we have a lithium-induced diabetes insipidus with amiloride, and indomethacin. So now you guys are diabetes insipidus experts, but how would they ask you about this on a board style question? Well, something they might ask you is a G2, P2 woman from 1 day post spontaneous vaginal delivery complicated by blood loss of 2,500 mLs, presents with polydipsia, polyuria, dehydration, and confusion. History is remarkable for no prenatal care, and bipolar disorder, which is well controlled with lithium, which this woman has continued to take throughout her pregnancy. The patient receives 1 dose of vasopressin without change in her urine. What is the most likely mechanism for her underlying condition? Okay, so you have a patient who's presenting for polydipsia, polyuria, dehydration, as well as confusion. This seems pretty classic for diabetes insipidus. This should definitely be on the differential. But if you look at our different clues that they gave us, she had an ischemic event, so she had a ton of blood loss during her delivery, which could definitely lead to Sheehan syndrome. She also has a history of taking lithium, so she might have peripheral or nephrogenic diabetes insipidus as well. And the question that they asked us is, what is the most likely mechanism of her underlying condition? Well, it's pretty hard to distinguish between these two because the symptoms in the presentation would be pretty much the same. The final clue that they gave us was that they gave her 1 dose of vasopressin without a change in her urine. So they did the vasopressin challenge and there was no change in her urine volume or concentration, and that's what's going to tell us that we're talking about peripheral nephrogenic diabetes insipidus here instead of central. So if they ask you about the underlying mechanism for peripheral nephrogenic diabetes insipidus, because you watch this video, you're going to know that the correct answer is going to be something like insensitivity to ADH at the collecting duct, or something to do with these V2 receptors. That is going to be the underlying pathology for her peripheral or nephrogenic diabetes insipidus. Now, that's all I have for you on diabetes insipidus. I hope you're a lot more confident answering questions about it on step 1, and I'll see you next time.